So I'm going to talk about acute flaccid myelitis. How many people in this room have treated or seen a patient with acute flaccid myelitis? All right, so that's most of the room. I'll try to then go through the slides fairly quickly. So basically what it is an acute flaccid paralysis with no involvement of sensory or any other nerve functions. So this is the incidence in the US by the CDC, and you can see a big spike every 2 years peaking around September. So here's what we know. Most of these patients are children. It's similar to polio. To date, really no consistent pathogen in the CSF has been detected, but it's thought to be an enterovirus mediated injury. There are some animal models which point to both injury at the nerve level and also at the muscle level, with perhaps the virus entering and attacking the muscle first, and then going up the nerve, and into the spinal cord. The presentation, again, is no spasticity. It's all flaccid paralysis, sympathetics intact, sensations intact. Classic imaging for an MRI is you see this owl eyes on the MRI. And then from a prognosis standpoint, I think very few people or very few children recover normal function of the arm, but they do make some initial improvements. We've not seen any meaningful recovery after 9 months post-injury, even in the longer term. So treatment options are as you see here. We've treated, now we're closer to 45 patients, but at the time of this study, 32 patients treated between 2007 and 2018, 16 of which underwent nerve transfers. Surgical indications are basically what you would guess: no or minimal recovery at 6 to 9 months from injury, and no other options other than nerve transfer, really, and expendable donors. Minimum follow-up of 6 months. We did 2 intercostal diphrenic nerve transfers, and one girl, who's a 14-year-old girl, improved her ability to speak and sing, and a 6-year-old boy who we did 16 months from injury, who 2 months after surgery succumbed to a mucus plug, and I think he was too late. This is the list of nerve transfers we've done, so a fairly robust list, because you have to find anything you can find and be fairly creative in finding a nerve donor. So when we transferred to suprascapular and axillary, we had 9 of those patients. You can see our average AMS is 2.6 on a 7-point scale for AMS, and that's fairly poor. However, when you look at biceps, brachialis, and triceps, the results were actually quite good. So elbow flexion, we've been able to do a really good job with. Everything else, the shoulder has been pretty poor. This is a really nice view of the recovery after surgery. And you can see this heat map. There's a lot of red in the pre-op and a fair amount of green in the post-op. So we have been able to make a difference in these kids, at least in the elbow. I think the shoulder is still vastly improved. If you look at the top row, shoulder abduction and shoulder flexion, shoulder external rotation, there's certainly a lot more green and a lot less red. So summary of results, 9 patients that we did transfers for suprascapular and axillary, only 1 of them achieved abduction of 6, and 1 achieved abduction of 5. The rest were 4s and below. 1 achieved external rotation of 7, 1 had a 6, and 4 had a 5. But all of them resolved their pseudosubluxation, so they did not have an unstable shoulder. Of the 6 patients that we did biceps or brachialis, 3 of them achieved an AMS of 7 and 3 an AMS of 6. And then transfer of the biceps and the brachialis in 1 patient that was 17 months out had a 5. Of the 4 patients that we transferred to the triceps, 3 of them had a 7 and 1 failed after 8 months. So I would say that nerve transfers are a very good option, but for some reason, and we think it's because the shoulder has had a primary injury to the muscle itself, we've not been able to recover shoulder as well. And I will concede my 15 seconds. Thank you very much.